Antivenom will always take care of multiple poisonings like the Elafidae as well as the Eucridae. But the monovalent may be very specific. If you know a particular type of the victim is able to identify the type of snake which has bitten him or brings the snake which has been killed by other people, then you can go in for a monovalent vaccine instead of exposing him to the polyvalent type. But in case of non-identification of the type of snake bite, then you have to go for polyvalent to take care of all the varieties of venom that could have happened. And even if the patient has some allergic reactions, it has to be managed with doses of epinephrine and antihistamine, and you have to complete the dose of the antivenom. So it may not be very severe, may not produce very drastic, but slowly you can give the antivenom and try to counteract the venom that has been injected into the patient. So I'll just show you. Is it visible now?
Yes, sir.
Okay. So the clinical effects of snake bite, it can be classified into local effects. Like we can see the bite site where there may be swelling, blistering, bruising, or necrosis. Or it may, if the patient comes a little delayed, it may result in what is called an acute compartment syndrome if the bite is quite deep. Or venom ophthalmia from entry of venom droplets or spray into the eyes. That is one point also you have to include in your answer.
Okay,
So
sir.
sometimes, some snakes have the habit of spraying their venom into the face. That will get into the eyes and produce very severe reaction, which will produce intense pain, redness, blepharitis, blepharospasm, and corneal erosions. So these are all the local effects that you will get. Systemic effects will be, you can classify them into vascular, where there will be clotting failure, platelet abnormalities, and vessel wall damage. Our patient may be in shock from bleeding and plasma extravasation systemically or into swollen, bitten limb getting swollen and necrotic, myocardial dysfunction, pituitary bleeds, vasodilatation, sepsis, anaphylaxis. All this can be various presentations. And the second important type of systemic effect is the neuromuscular effect, where paralysis happens. So earlier books classify the venom into hemorrhagic type of reactions as well as neurolytic type of reactions. These are the two types which are classified. Later on, they added the acute kidney injury also, which can be caused due to various reasons, which also has a direct effect of the snake venom, which I'll show you the etiology. So paralysis by action of the at the nerve, it may act at the presynaptic level at the nerve terminal, or it may act at the muscle level in the postsynaptic at the neuromuscular junction, which will cause weakness of the muscles. So patient will present with ptosis, diplopia, or blurred vision, and this can be followed with a sequential bulbar weakness, which can be, as she said, the 5Ds, dysphagia, dysphonia, drooling. If these things are all found out, that means the bulbar paralysis is setting in. That is the brainstem is getting affected, and it will later on lead to respiratory and limb muscle paralysis also. And there will be another type where there will be generalized muscle restriction, which may be in the form of rhabdomyolysis, which is cells in the affecting especially the neck, trunk, and proximal limb. And because of rhabdomyolysis, the urine will be dark in color. Whenever the patient has that, you have to make sure that the muscles are affected, which will be the reason. The acute kidney injury is likely to usually because of the secondary effects of hypotension or fibrin platelet clot formation in the capillaries and arterioles, or it may be a immune heme related tubular damage, or sometimes the venom directly can affect or damage the kidneys, the nephrons. So, four reasons for the acute kidney injury: secondary to hypertension, secondary to fibrin platelet, the thrombi forming in the capillaries and arterioles, and tubular damage caused by the heme or the immune factors, and direct venom effect on the tubules. And patients, how do they present? They may present with a history of seeing a snake bite or feeling a sharp, painless bite, which will be happening in cases of, painless bites also can happen with crates, as we mentioned, during sleep, and patient wakes up next day with symptoms. He doesn't realize anything that is happening. And if they have seen the snake and experience the bite and visualize the bite, then they go in for severe fear and anxiety will be setting in. And bites may be painful, which may be mistaken for a punctured wound from a thorn or a sharp stone, and the patient may ignore also. But the fang marks, the two puncture wounds, which are called the fang marks, is a very important clinical thing which you have to look for specifically and identify. And some patients may be bitten by highly venomous snakes and may result in immediate cardiovascular collapse, unconsciousness, bleeding, or paralysis. It depends upon the snake, especially cobra bites are very poisonous, and that may result in immediate cardiovascular collapse. And if the patient is conscious, they may experience nausea, vomiting, abdominal pain, which are all non-specific symptoms. But they may be the heralding serious complications of uremia or acute pituitary and intracranial bleeds or anaphylaxis. So don't ignore them just because they have these common non-specific symptoms. Now, first aid for snake bite is reassure the patient about prompt first aid and medical assistance to allay the fears. Arrange rapid transport to the nearest medical facility. Make sure that the facility has anti-venom in stock. And also, they should have critical care support. So don't just from a primary health center, there is no point in shifting to another primary health center. So you must shift from an area to a tertiary center where anti-snake venom will be available all the time, and critical care support, especially dialysis support, should be available in case they develop acute kidney injury. So you must shift them only to such places so that they can be salvaged. And immobilize the patient, especially the bitten limb should be immobilized, as he rightly said, like as you do it in the fracture case. And earlier they were advocating pressure immobilization, but later on it has been found that applying a tight bandage and pressurizing the area is not a good choice. It's only in cases of neurotoxic elapid bites you can do this. For other cases, it is simple immobilization is more than enough. And so three things in first aid. One is reassure the patient, transport the patient, don't make them walk to the center where antivenom is available as well as critical support is available. Immobilize the patient as well as the limb which is got bitten. These are the three first aid things which you have to remember. Coming to the management, resuscitation and supportive care, and you can divide it into antivenom treatment. These are the two categories of snakebite management: resuscitation and supportive care, administration of antivenom. So admit all snake bite patients, whether they are bitten by poisonous or non-poisonous snakes, if you can't identify the type of snake, for a minimum of 24 hours for observation. Promptly manage airway, respiratory paralysis, shock by restoring airway, oxygen intubation, assisted ventilation as needed with IV fluids. Avoid aspirin and other NSAIDs because that may aggravate the bleeding that may be already happening because of the hemorrhagic type of venom. Monitor vital parameters, especially urine output, because these patients can go in for acute AKA. And the 20 minutes whole blood clotting time can be repeated frequently to find out whether the coagulopathy is occurring or not. Even if the initial test is normal, it may become abnormal after 6 hours. So, as we rightly mentioned, every 6 hours, when the patient is staying as an inpatient, we have to repeat this test to make sure there is no delayed effect of the venom on the body. Next, coming to the antivenom treatment, guidelines by WHO say treatment is a must for patients with shock, spontaneous systemic bleeding, uncoagulated blood, neurotoxicity, black urine, acute kidney injury, rapidly progressing local swelling, or bites by species known to cause local necrosis and digital bites. In all these cases, antivenom should be given. Antivenoms are nothing but whole or fragmented immunoglobulins which are fractionated from the plasma of domesticated animals. Usually they inject small quantities of venom in the horse and take the plasma of that horse and then prepare this antivenom from that, which is nothing but a whole or fragmented immunoglobulin. And these animals are hyperimmunized with them to prepare this. And polyvalent antivenoms are raised against a mixture of different types of snake venoms. So this will be helpful in managing both the Elapidae as well as the Vitridae types of snake bites. And as I said earlier, if you know that if you have identified the snake which has bitten the patient, then you can use the specific monovalent venom for the patient. And the early administration prevents the prevents the limits of hemodynamic alteration, progression of coagulopathy to clinically overt bleeding, and neurotoxicity is also prevented, myotoxicity is reduced, and acute kidney injury and local tissue damage all will be reduced by early prompt administration of the antivenom. Now, physiological levels of clotting factors may be partially restored within the 6 hours if you administer the antivenom in time. All the abnormalities of the clotting factors will be restored within 6 hours. And administration is always intravenous, no intramuscular or at the site of bite. You should never inject that. It is always intravenous. And it can be a slow bolus given over a period of 15 to 20 minutes, or it can be diluted in saline and given over 10 to 60 minutes. And repeat administration after the initial doses. The second, usually one dose will be sufficient. You may not have to repeat the dose, but repeat administration is indicated if bleeding persists or if weakness or cardiovascular signs become worse. If the 20 minutes whole blood clotting test becomes positive after the 6 hours, first test is negative. After 6 hours, when it becomes positive, then you have to give the antivenom. That is not called the repeat, but that will be the primary first dose. And dose of antivenom, it is available as vials. There is no units or milligrams that is available. So it is just called as vials. And for mild, moderate, and severe cases, it is how some books classify. For mild cases, you have to use 3 to 5 vials. And this is, as she mentioned, it may be available as a ready-made liquid or a lyophilized powder, which can be dissolved and we can prepare that. So mild cases 3 to 5 vials, moderate cases 5 to 10 vials, and severe cases 10 to 15 vials is the dosage. And after this antivenom treatment, the other supportive treatments are neostigmine with atropine in cases of postsynaptic neurotoxins, where patient has neuroparalytic effects like ptosis, paralysis, and all these things. You may have to give this to reverse that because it reduces the amount of acetylcholine that is available. So you can use anticholinergic and prevent the side effects of that neostigmine with atropine, just like we reverse the neuromuscular blockade after a non-depolarizing muscle relaxant. In neurolytic person, you can use this as a dose of 0.6 milligram of atropine and 1.5 milligrams of neostigmine, given as a slow IV bolus, followed if necessary repeated doses. And if the patient has already got respiratory paralysis, then the patient requires intubation and treatment. But milder cases can be reversed with this the so-called NA challenge. This is called NA challenge, where you can use this and reverse that without putting the patient on ventilator. And administration of tetanus toxoid booster is very much important in all these patients, except to those with coagulopathy, whose injection is postponed until hemostasis is achieved. And aspirate large dense bullae to facilitate nursing the bitten limb, preempt spontaneous or don't allow spontaneous rupture and prevent secondary infection. Broad spectrum antibiotics are indicated only if the wound has been incised by somebody outside or there are signs of necrosis or wound infection or abscess formation. Surgical debridement or amputation of gangrenous digits or limbs and skin grafting may be needed later on. Okay? And there is an algorithm given in a book which is for the management of snake bite poisoning. If you can remember these steps, it may be easy to reproduce in the exam. So history of snake bite is given by the patient. Perform rapid primary assessment. Then the cardiorespiratory arrest or critically ill patient. Then if the answer is yes, go for resuscitation, stabilize the vital parameters, look for evidence of both local and systemic venomation, collect laboratory samples, administer antivenom urgently in these cases, arrange emergency transfer to hospital with critical support. That is, at the site of injury, nobody will have that, but once the patient reaches the hospital, antivenom should be given as early as possible. But if the patient is not that critically ill, he is just conscious, talking, and he has been brought in a stable hemodynamic status, reassurance is the first thing. Collect history and perform physical examination. Perform the 20 minutes whole blood clotting test. Infer likely biting species. Try to identify what type of snake has bitten the patient. And then laboratory and clinical evidence whether the patient has really been bitten by a poisonous snake or not can be found out by the WBC test, as well as any evidence for neurological involvement. And if there is no features of either hemorrhagic or neurolytic poison, examine for signs of envenomation at 2 hours, 6 hours, 12 hours, 24 hours. And by performing the repeated 20-minute WBCT test. But if the patient is positive for all that, immediately administer antivenom, monitor for early adverse effects. And keep the monitor. I mean, if the patient has no features of inflammation, then discharge after 24 hours of monitoring. But if the patient has features and the antivenom treatment has been given, observe the patient till the patient completely recovers from the effects of the poisoning. And then discharge, review for serum sickness later on, because the patient may develop a late complication called serum sickness because of both the antivenom treatment and simple rehabilitation of, for example, limb exercises also can be given to the patient. Okay. So this is what I can write about snake bite.